Hello, friends. A warm welcome to another episode of 4D Details, Discussion, and Dialogue in Indian Diabetics. This is a series where we have three specialists with us, an endocrinologist, a cardiologist, and a nephrologist, to talk about interesting aspects of metabolic diseases, the non-communicable diseases, which are the biggest challenge of this modern era. And today our topic will be personalized therapy in cardiorenal metabolic syndrome. Now, if you look at, CRM, cardiorenal metabolic syndrome, we understand clearly that these are not three separate diseases. Cardiac disease, diabetes, and the renal chronic kidney disease, they go hand in hand, they are interconnected, and there is a progression of each one of these across a continuum. And if there is involvement of one, there is obviously, it pulls the other disease along in a fast forward motion, so that our approach has to be uniform. It has to be united, it has to be integrated with patient in the center. That's why personalized care, individualized care is very, very important. And we also need to understand from the perspective of each one of us, what the other specialty is doing, how they are improving care, and how we can find a common ground. So in this regard, there is a very good शायरी of that's in Urdu. मैं अकेला ही चला था जानिबे मंजिल की तरफ, लोग साथ आते गए और कारवां बनता गया. So it's more about, having an integrated care, making that karma of care for our patients to improve their outcomes right from the word get-go. It is my extreme pleasure to invite three specialists with us. We have Dr. Sumant Reddy. He is a DM cardiologist from Narayanadri, Tirupati. Warm welcome, Dr. Sumant. Great to have you today. Then we have Dr. P. Sunita. She is a DM nephrology. She's a senior nephrologist at Aster Narayanadri Hospital, again in Tirupati. A warm welcome to you, Dr. Sunita. And our third panelist for the day is Dr. Likitha Reddy, an endocrinologist, DM in endocrinology, again from Aster Narayanadri, again in Tirupati. So, warm welcome to you, Dr. Likitha, as well. Now, before we begin this discussion, how is the weather in your part of the country? Because we have, 6-7 degrees here in the night, 14-15 degrees in the day. Flights are getting cancelled. So, how is the weather in your part?
It's 14 degrees in the night and around 20 degrees in the morning, which is very much cool for us. We have temperatures of 45 degrees in summer. So this is relatively very cool winter for us.
So we should actually be holding this in person in Tirupati at this time of the year. Yeah. So starting with you, Dr. Likitha, again. So when we talk of diabetes, the focus earlier has been, a lot of people have debated that, glucose-centric approach is good enough, that UKPDS showed that if you improve control, you improve outcomes. And there was a lot of focus on just, fixing the numbers in terms of glucose values. Then we had the Steno-2 trial showing that no, you need to really go in with a multi-factorial approach. But for a long time, we didn't really have any drugs to improve hard outcomes, in the sense that, improvement of control, improvement of BP control will improve things. But we didn't have these drugs. So how important do you think is going beyond a glucocentric control as far as cardiovascular risk reduction and kidney risk reduction is concerned?
Whenever I start my talk everywhere, I keep telling them diabetes is not just control of numbers. You just can't treat your FBS, PPBS. It goes beyond that. You have to have an inspect into the person's phenotype or his family history. Were there any diabetic complications in his parents or grandparents or siblings and all? And the treatment should be more of a complication-based approach. So we have to anticipate what the complications, diabetic complications, microvascular or either macrovascular, he might be landing into. So we have to go according to them. Previously, I don't think there was much of these drugs. They were mostly sulfonylureas, metformin, and insulin, basic types of insulin. So they didn't even have this chance of going into treating this macrovascular complications and all. So now with the advent of pharmacotherapy, I think we have a large range of molecules.
So I think what Dr. Likita has been trying to highlight here is that deciding therapy would be based on a risk factor assessment and an assessment of the phenotype of the person. So, and the phenotype, we use a term that's called glucophenotype. Glucophenotype is, what is the level of glucose elevation in a person, how high the HbA1c is. And then some people have different glucophenotypes, like some have fasting hyperglycemia, some have predominant postprandial hyperglycemia. There are some others who have a lot of glycemic variability. So again, the treatment needs to be tailored on that. But beyond glucophenotype, there are so many other aspects: the blood pressure, what is the cardiac risk, what is the risk of CKD in the individual, background, family history, is there MASLD in the background, what is the body weight and BMI, is there obesity that we really need to consider, and hypoglycemia risk. So all of these things need to be taken into account when we tailor treatment. So that's the approach. Dr. Sunita, looking at it from chronic kidney disease perspective, what do you think is the burden of CKD in diabetes in India? Because I think 10 years, 15 years back, we used to say the commonest cause of CKD is not diabetes, in our country at least. But now we are seeing most of our patients that are, if I go to the dialysis ward for any reason, for a consult or something, I see so many people with diabetes. So what is the true burden now?
Actually, like India is a diabetic capital, everyone knows. And initially it used to be like glomerular diseases and congenital disorders. Now it is like diabetes is the most common cause of CKD. And if you take type 2 diabetes, mostly 40% of the patients will develop this CKD, like within 5 years. Like at the time of diagnosis also, it is like not surprising to see a patient at the time of diagnosis itself as having a patient with like high creatinine, with significant albuminuria, everything. Like it is like very high burden. It should be treated early, addressed early, and monitor to prevent long-term complications. A patient going into like end-stage renal disease, we have to take individualized measures and regular follow-up. And it is very high, and it is going to be very high also in the future.
True. So it's actually rising and becoming the most common cause of CKD in India now. So how does CKD impact the management of people with diabetes? Like what differences would you think are essential once a person has developed CKD?
Actually, it won't differ initially depending upon the creatinine levels and depending upon estimated GFR levels. Usually, if it is less than 45, we'll tailor the treatment. And because these patients, if the GFR is less than 45, these patients more prone to go into hypoglycemia, and the complications, microvascular complications, will be more in these patients. So if it is less than 45, like stage 3B, what we call as 3A, 3B, and we have to tailor accordingly to the need of the patient. And we have to prefer renal safe and along with renal protective drugs.
True. So it really is important from that perspective. And looking at it also from the cardiovascular disease perspective, do you think there's an interrelationship between chronic kidney disease and cardiovascular disease? Dr. Sunita, if you'd like to address that.
Sorry, can you repeat the question?
In patients with CKD, do you think the burden of CVD is also higher? Like they have more cardiac diseases?
Yeah, definitely. Both are renal is micro and cardiac is both micro and macro. It is going to be it is very high. And CKD patients, the most common cause of morbidity and mortality, it is CVD outcomes only. CKD itself, it won't cause drastic complications, but the main cause of mortality in CKD patients is the cardiac outcome.
So most patients, before they even need they reach the stage of needing a renal replacement.
ESRD, renal replacement therapy, any mode of renal replacement therapy, most of the patients, they will land into heart failure or some other arrhythmias, whatever other things, and they will be needing a cardiologist opinion earlier than the nephrologist opinion.
True. That brings me to Dr. Sumant. So, looking at your cardiology practice, we see a lot of people who are coming in for maybe an angioplasty, or they may not have diabetes, but they have all of the clustering of risk factors like pre-diabetes. And quite often, patients say, we underwent a PTCA 10 years back. We were told sugars were borderline at that point of time, but then we never, looked at it again. So, how common do you think is dysglycemia in your population, number one? And do you think an assessment for metabolic syndrome is really important at that stage?
Yeah, definitely. So most of the patients who are admitted under it, most likely due to the acute coronary syndrome. So most of these patients will be having diabetes. And CKD, because we don't do an angiogram for the CKD or the renal dysfunction patients, most of the patients will have diabetes, but doesn't have renal dysfunction. And these patients usually they will have a definite evaluation for his lipid profile and his glycemic status. And his glycemic status, most of the patients will even be having de novo diabetics, where we'll be having an endocrinology consultation and starting him on anti-diabetic drugs. And most of the patients will be diabetics, whether they are known or de novo. And without depending much on the diabetic status, our interventions will remain the same. Whether they to proceed with the angiogram or to proceed with the stenting, that will remain almost the same. Only difference is in patients with diabetics with borderline disease, will be preferring bypass surgery compared to stenting. And apart from these cardiac interventions, his glycemic status need to be taken care of. And if his sugars are not controlled, the problem is they will have a stent thrombosis after the procedure. And also the patient coming to our OP or emergency ward in the first month of stenting, because most of the patients will have recurrent cardiovascular or acute coronary syndromes, either due to the same vessel or due to lesion in another vessel. So our treatment remains basically the same, but the glycemic status will have to be taken care of definitely.
So the success of the coronary intervention also will be impacted by if the control is suboptimal from glucose point of view also. I think we had the Digami 2 trial, which clearly showed that the outcomes do become worse in these patients. Again, coming back to you again, CKM, there has been some staging systems that the American Heart Association has given for chronic kidney, the cardiorenal metabolic or cardio-kidney metabolic syndrome. Can you tell us something about that staging system?
Yeah, staging is definitely useful, not only for either while admitting the patient to diagnose him, and also to prognosticate him, and also during discharge, especially to optimize the doses of the medication, whether we have to keep him on lower dose or whether we have to keep him on higher doses. So staging is useful not only for the prognostication of the patient, but also the treatment will be affected, and the treatment depends mainly on the staging.
Yeah, so earlier the stage, we can intervene early, of course, in earlier stages, but as the stages increase, we have to go more intensive with our care. Dr. Sunita, when we talk of kidney disease, are there specific markers we use that can predict one, progression of kidney disease, and also progression of cardiac disease?
Yeah, there are markers, but they are not ideal. But still, we can by repeating them at specific intervals or depending upon the condition of the patient, we can assess the patient. One is the protein serum creatinine (RFT), and the thing is albuminuria. Depending upon the micro macro, it used to be initially. Now it is the terminology has changed. And another most recently developed and not recently, but reliable marker is cystatin C. So by using this cystatin C, albuminuria, urine albumin excretion, and serum creatinine, we can assess the patient and tailor the treatment.
True. So, at what point do you think you would look at cystatin values? They're not routinely available in most labs.
Yeah, it is very costly.
Yeah. As of now, where would you suggest that we do those?
creatinine mostly depends on the muscle mass build of the patient. So if it will be like better if we use both cystatin C and creatinine, but cystatin C is not like in our part it is not available. And if it is available also, it is like very costly. So we routinely depend on like serum creatinine, and we'll measure it like regular intervals, and we'll, depending upon the changes, we'll instruct the patient to change the medication or to come like close follow up or something like that. And like albumin levels, urine albumin levels, it is a reliable marker. More than protein, albumin in diabetic patients, like metabolic patients, it is like reliable marker.
So, Dr. Likita, when we are considering, assessing a patient with diabetes, so let's say the person has come to you for the first consult. So, what are the factors you're looking at, and what tests would you advise?
First one would be his BMI, his weight hip ratio, the amount of visceral adiposity he has. That are the basic things I look into. I ask for a family history. I'll get his routines like fasting blood glucose, postprandial HbA1c, and I would postprandial would throw a lot of insight into his things. I feel, and later on I get a spot the urine microalbumin, spot urine creatinine to know if there is any microalbuminuria, his protein creatinine, hemoglobin levels, and especially lipid profile to look at his LDL levels and apolipoprotein levels. And I don't go for any invasive ECG or echo to look into his cardiac thing, but I just ask him how is his exercise capacity. Is he able to walk properly with comfortably, anything during any discomfort or dyspnea during walking? So I just want to look into his basic fundus. So these are the things which I look into routinely, and routine urine examination. And basically, as you were speaking about the staging of CKM, stage 0 is an apparently healthy individual, where one is a person who is at metabolic risk, like having obesity without no apparent renal or any problem. Stage 2 is where he's having kidney disease, either microalbuminuria and with high metabolic burden. And stage 3 is person where he has kidney disease but no apparent cardiac disease. Stage 4 is subclinical heart disease with a diastolic dysfunction or any LV hypertrophy or an LV strain, echo strain. So I just try to categorize him where he falls, where should I look into his. If he's just at a metabolic risk, I give him mostly pharmacotherapy and lifestyle modifications. Now, with the advent of GLP-1 receptors, patients' obesity is very easy to be treated, and they are actually so good.
Yeah.
So, if there is a much metabolic burden or increased visceral adiposity and all, I start them on GLP-1 receptors, and before that, the routine test, ultrasound abdomen. Is there anything which I be adding, ma'am? Please.
No, I think you've covered most of it. So I'll just ask that Dr. Sumant, being the cardiologist in the house, do you think we should just do a symptom screen for cardiac disease? At what point should we start investigating with ECG, echocardiography in people, let's say, just newly diagnosed diabetes also?
All newly diagnosed diabetics should undergo at least an ECG. So for diabetics who have crossed 5 years, it's better to undergo an echocardiogram as well. And for those diabetics who have crossed 10 years, it's always better to go for an ECG and echocardiogram every 1 year at least.
True. So that's actually, I think we are not screening enough from that perspective. And we also now have data that at least a quarter of the people with diabetes do have heart failure. Even if it's in the early stages, we might not actually be picking it up. In the same regard, how important is LV diastolic dysfunction, Dr. Sumant? A lot of our reports come with, grade 1 LV diastolic dysfunction or grade 2. At what level does it become clinically significant?
For patients aged above 40, so grade 1 diastolic dysfunction is normal. So that can be taken as normal. So grade 2, grade 3 and grade 4 diastolic dysfunctions are actual diastolic dysfunctions. So most of the patients will be having either 2 or 3. Grade 4 is very rare. And diabetics, it doesn't differ much, the diastolic heart failure. But especially in patients with diabetic with CKD, then the patients will be having hypertension, the patient will be having left ventricular hypertrophy, and that leads to elevated LV diastolic filling pressures, finally leading to diastolic heart failure. So for a prolonged patient with prolonged diabetes having nephropathy, or a non-diabetic having CKD. So due to hypertension, patients will be having the LV hypertrophy. That is the main reason. And if they use beta blockers from early on and treat hypertension adequately, the LV diastolic pressures can be lower, and the hypertrophy can even be reversed, and the diastolic heart failure can even be reversed. And treatment more or less remains the same in patients with diastolic heart failure. It remains similar to the systolic heart failure. And needing diuretics in patients with the only difference is the amount of dosage of diuretics given in a normal patient differs significantly in patients with CKD, because their kidneys won't respond to the normal usual dose of diuretics which we use, and they will be in a CKD stage 2, 3, or 4. They will be requiring very high dose of diuretics, and CKD stage 5 they won't respond to it. So whatever the amount of heart failure the patient is in, we still have to depend on nephrologists for dialysis to clear the symptoms.
True. So on that note, coming to Dr. Sunita, so when we are talking about diuretics, you are the expert on that more than all of us. So at when do you prescribe diuretics in your practice, and how do you decide whether it just has to be a loop diuretic or it should be a mixture of loop diuretic with MRA?
Actually, it is not like clinically when the patient is like volume loaded or something like that. Dr. Suman told, if he has like preserved EF also, if there is like congestion, not clinically evident peripheral edema, still we will go with diuretics in initial stages itself. Because diuretic itself, it is one of the first prescribed drug for treatment of hypertension. As usually diabetic patients with CKD usually will have hypertension, so we'll go with low dose loop diuretics initially. And if the patient becomes with progression of the decade, diabetic kidney disease, treating this edema, because of this albumin loss, protein loss, everything, edema will be very difficult. So we'll go with sequential blockade, with a loop diuretic and a diuretic acting on DCT also. So with this, the fasting should be monitoring of sodium and potassium. And along with this, the complication electrolyte disturbances will be more. So we'll go with aldosterone inhibitor also, preferably non-steroidal. And adding to this, to prevent this, to decrease this hyperfiltration at the glomerular level, we'll go with SGLT2 inhibitors also.
True. So what are the other nephroprotective drugs that you would want to see in the prescription for people with CKD?
Yeah, first thing is there will be RAS activation, activation. So at any stage given, if possible, if there are no side effects, I want to block every stage of the RAS, starting from renin to aldosterone. But hyperkalemia is again a problem in especially CKD patients. Whatever is the dose patient is tolerating with a normal potassium level, we'll go with ACE inhibitors or ARBs. And the second thing is SGLT2 inhibitors, that is the most proven renoprotective drug as of now. And the last thing is non-steroidal mineralocorticoid inhibitors. These three are renoprotective, and if used cautiously, it can delay the progression of CKD very effectively.
So, do you have a checklist when you're starting something like a Finrenone molecule? Do you look at a checklist, or what? How do you follow up the patient after starting?
Yeah, usually we'll go with serum creatinine. Based on that, we'll calculate eGFR. If it is more than 25 ml, it is safe to start Finrenone. And after 15 days, 2 weeks, and we will again see the potassium levels and serum creatinine levels. Usually there will be hyperfiltration, so there will be asymptomatic rise in creatinine and potassium. The patient is tolerating well, and again we will continue after for 2 more weeks or 1 month, and again we will check if the patient is stable and there are no increase in these things, and we will continue. And if the desired effect is not there, the reduction in all protein expression, we can increase the dose, double the dose safely if patient is tolerating.
So start with 10 milligrams, and if the
Yeah.
albuminuria reduction is not significant, you can increase to
Yeah.
20. And
Yeah.
do you use a potassium cutoff at which level you don't start or when you stop?
Yeah, more than like stopping, we'll go for other things like potassium lowering agents, because these are like proven renoprotective agents, right? So till the patient tolerates these drugs and potassium levels still like 5.5, more than 5.5, also we will try to decrease potassium by adding other potassium lowering agents than decreasing this drug. If the patient is still not tolerating and he's developing like EC changes, everything, we'll stop the drug, and we will monitor the patient. If the potassium levels become starts to come to normal level, again we will try to restart with the lower doses, and we will monitor closely. And if the patient is like doing well, we'll continue the drug. And if the patient develops in like hyperkalemia, then we will stop it like that.
Right. Dr. Sumant, coming to you again, we are still going around the diuretic equation only. So when we talk of, it's a very common practice to use a combination of loop diuretic with aldactone. Eplerenone is also still expensive, and now we have finrenone. So how do you prioritize which molecule to choose in which patient? Like, is there a cutoff, or you think finrenone is the better molecule for all?
Yeah, definitely. When I am choosing the diuretic, we have to combine, because the four pillars of heart failure, it includes mineralocorticoid receptor antagonist. We have to definitely use a mineralocorticoid receptor. Unless the patient has the CKD with creatinine greater than 2.5 or the hyperkalemia with potassium greater than 5.5, we usually combine our diuretic agent torsemide or furosemide with aldactone usually. But most of the patients, especially with spironolactone, these patients will be having gynecomastia. So for female patients, I usually don't, depending on the patient financial condition, I will prescribe either aldactone or eplerenone. But in male patients particularly, most of the patients will be coming with gynecomastia. So I prefer using eplerenone even in without looking at the financial status of the patient. And finrenone has the main difference between finrenone and eplerenone is right now the cost. So I am choosing depending on the patient. If the patient is affordable, I am going with finrenone because it is more selective and has lesser side effects. And if the patient is not affordable, I am going with eplerenone. Right now, in male patients, I am not preferring spironolactone at all.
True. So, looking at evidence-wise, do you think the evidence is stronger for one molecule than the other molecule? Of course, there are no head-on comparisons, but from the trials, what is your opinion?
Of course. So Finral being the new addition, so Finral is obviously better compared to eplerenone, and eplerenone is obviously better compared to the spironolactone. So without considering the cost constraints, definitely the first choice has to be the finrenone. Only if the cost constraints come in, because the patient will be almost taking the drug for lifelong. Because if the cost constraints are there, they have to go for eplerenone, and I don't prefer spironolactone. So without the cost constraints, it's better to go with the finrenone.
True, that's true. And you will be adding finrenone, and Dr. Likita will be adding GLP-1 RA, so the cost really becomes an issue. So, Dr. Likita, you were talking about GLP-1 receptor agonists. We have so many molecules in that basket. So, do you think all GLP-1 RAs are same? How do you categorize them? ADA has given this chart wherein some are high efficacy, some are very high efficacy molecules. So, can you tell us about that?
Mostly previously we had only one when it was only semaglutide or ribosas. I used to give most of our patients the same. Now with we have Wegovy, recently we have even Ozempic and even Monjaro. The thing is, I kind of motivate them for taking a weekly once injection, even though they are needle phobic. Also, I try to tell them, or I try to motivate them, or whatever takes to me. I make them sit and I tell them, even the cost is more or you're insulin phobic, needle phobic, this adds so much to your life years. You have many complication free life years ahead of you and all. Depending upon the phenotype of the patient, if the patient is having less muscle mass, or if I feel they are very having adipose tissue and visceral fat, I generally go towards Monjaro. That is a peptide. I shouldn't be taking the name of it. But patients with type 2 diabetes and who are not so obese and who do not need so severe weight loss, I go for a lower doses of semaglutide also. I think better the side effect profile as far as till now tirzepatide has a slightly smoother way of progression, or if I hike even the doses also, the transition from 2.5 to 7.5 or 12.5 is it's very smoother with tirzepatide. But yeah, I had faced certain issues with semaglutide with the side effect profile, not with the weight loss or reduction in glycemic parameters, but the side effect profile is slightly better with tirzepatide, and patient acceptance is also more with tirzepatide.
True. So in the current armamentarium, we had been using liraglutide and dulaglutide also. They are still around, and liraglutide, in fact, is still a lower cost molecule. Where do you see a place for these in your practice? Like, are you using it, or has it just been phased out?
It to be frank, it has been phased out in my practice, ma'am, because I insist on people if they are willing to spend. I ask them to take tirzepatide or semaglutide for a period of at least 6 to 8 months, and I think that has more efficacy. I mean, if I'm talking in terms of loss, weight loss, and all. If I'm speaking something for a person with normal obesity without much visceral fat, then who are people who are actually on liraglutide are being continued on liraglutide. They are not being shifted if they are doing good on liraglutide, and if they have their ideal body weight and if they are comfortable, I continue with liraglutide. But newer cases who need more weight loss or with BMIs more than 27, I don't think liraglutide is that efficacious in this given scenario. Like when we didn't have much options, yeah, liraglutide was a wonder drug for certain period of time, but now I think we have better options and patients deserve the best.
So I think what Dr. Likita has also kind of highlighted, that we have a lot of GLP-1 analogs. They have been there for more than a decade and a half, I think. And we had earlier exenatide, which by and large has been phased out, because exenatide, the original molecule, needed to be given twice a day, which is kind of not very acceptable. Efficacy was lowest in the entire category. And the exenatide long-acting formulation probably never came to India, and it had a lot of injection site reactions also, but it was a good molecule otherwise. Then we had dulaglutide. Again, dulaglutide is a fairly good efficacy molecule. So when you look at the grading efficacy, dulaglutide and liraglutide are considered high efficacy glucose lowering agents. And semaglutide and tirzepatide are in the next generation of very high efficacy molecules along with insulin, because there the A1C reductions can go to the tune of 2.5 to 2.8% even. So that's the grading. But then weight-wise also, it's almost a similar grading, wherein liraglutide or dulaglutide can give you a weight loss of maybe around 5 to 6%. But tirzepatide and semaglutide in people with diabetes, the weight loss is around 8 to 10%. It's not 15 to 20% as in people without diabetes, but it's still a good amount of around 10%. So we can choose the molecule based on that. Looking at it from the cardiovascular perspective, there is evidence for dulaglutide, liraglutide, sema. These are the three molecules where cardiac risk reduction has been proved. Renal risk reduction is known with sema and dulaglutide, but the tirzepatide data for any of these is still lacking. Dr. Litka, can you also tell us about what are the differences, because a lot of people confuse, and yesterday in our group there was a question about how do you do dose conversion from tirzepatide to if a person is on tirzepatide, how do I convert to semaglutide? So are they same molecules? What are the salient differences between the two?
Ma'am, molecules are totally different, but I haven't converted any patient from tirzepatide to semaglutide as of now. There were a couple of patients who were weight neutral even on 5 after using 4 doses of 5 milligrams of tirzepatide. But there was a little thought in me, should I go to semaglutide in these patients? But I don't know. I wanted to give another 1 month, another dose of 5 mg of tirzepatide, and I watched. Right now they are having 2 to 3% of weight loss. When I continued it for the third month, as of now I haven't thought, but patients who are on semaglutide are continued on semaglutide, who are on tirzepatide are continued on tirzepatide. What I heard from my colleagues and my seniors when I speak, when you convert patient from tirzepatide to semaglutide, there are certain unseen side effects, and the patient wasn't comfortable with those, and there was change of even a practicing physician and the endocrinologist also. So I thought it is better to continue if the patient is doing good. If there is weight loss with tirzepatide, it is better to continue with that. And if there is no chance of weight loss with tirzepatide, I don't know, ma'am. You should give some insights into this. I haven't faced this issue yet because I have like 30 to 40 patients on these molecules. That's it.
So what happens is semaglutide is a GLP-1 receptor agonist, and it works only through the GLP-1 receptor. That is why its safety profile is similar. It's just that the GI tolerability in the initiation phase, people may have more nausea because GLP-1 does act on the area postrema, and the receptors are there, so it can trigger more nausea in those patients. But tirzepatide is a dual agonist of GIP and GLP-1. It has less potency on GLP-1, more on GIP. So that nausea side effect actually is less, and rather GIP may reduce nausea, GIP agonism. So that's one subtle difference. Then GIP is also involved in the adipose tissue pathways. So there's a slightly more lipolysis happening. That's why weight-wise, if you look at the head-on trial, tirzepatide does cause better weight reduction. But coming to, I think, people with diabetes, we can't hypothesize that the benefits of cardiorenal protection that we are seeing with semaglutide are going to come with tirzepatide. That's an extrapolation we cannot make, because a lot of those benefits, if you look at the SELECT trial, the cardiac protection is happening much earlier, even at 3 or 4 weeks, where weight loss hasn't even really started to happen. So it's probably GLP-1 agonism which is giving us the cardiac benefit than the weight reduction per se. So I think we'll have to take them as two separate drugs and let the evidence come for tirzepatide. But like you said about shifting from one to the other, yes, we cannot shift. If somebody is on 5 milligrams tirzepatide, we can't just say what is the equivalent dose of SEMA. You probably will have to start again from bottom up and slowly escalate the dose. The best thing is if a person is on a particular dose and the weight is plateauing, you increase the dose of that molecule and reach the maximum. A lot of people are, I think, staying stuck on one dose of 5 milligrams for 8 weeks, 12 weeks, and expecting results they don't really happen. So escalate it every month till you reach the maximum tolerated dose. I think this was a good endocrine discussion. Coming to Dr. Sumant, from the cardiac side, when we say heart failure, we've discussed a lot about heart failure. But when we talk of the risk reduction for atherosclerotic cardiovascular disease, so what is your portfolio or the list of drugs you add to patients?
The single most important drug usually we prescribe is the statin. So all patients with diabetes greater than 5 years should receive a statin. So for primary prevention without patients without having a atherosclerotic cardiovascular disease, we prefer a low or moderate intensity of statin, that is atorvastatin 10 or 20 mg and rosuvastatin 5 or 10 mg. And patients already having the atherosclerotic cardiovascular disease, either that can be CAD or CVA, we go for a higher dose of statin, that is 40 or 80 mg of atorvastatin or 20 or 40 mg of rosuvastatin. And only in selected patients who are having hypertriglyceridemia as well, we usually add a fenofibrate, or if the levels didn't decrease as we expected, we will add ezetimibe recently. So most of the patients will have adequate levels or target levels with these three drugs usually. So only in patients with some familial hypertriglyceridemia only we go for other drugs in patients with very high LDL levels. We go for this evolocumab or recently the inclisiran injections, which are very costly previously. Usually it was around 2 lakhs previously. Once in 6 months injection, as now the cost has decreased to as low as 40,000 per injection. For 6 months, it's okay for those patients. And the main thing is the lipid profile. And the other things which we look for atherosclerotic cardiac disease prevention as diabetics and hypertension status, if they have this, we should go on treating from this. Or if they don't have this, we have to keep screening them at regular intervals. And the metabolic activity of the patients, we have to see whether he is leading a sedentary life. And if he is leading a sedentary life, we have to encourage the exercise part of the bit. And the lifestyle includes both the food intake and also the exercise. So the exercise they recommended, as everyone knows, is around the brisk walking for at least 45 minutes per day for at least 5 days in a week. And brisk walking is not just a regular walking while talking with others. It has to be as brisk as possible. That is as fast as the person can walk. And the person, whenever it is a cardiac exercise, it has to be the patient has to stop not because of his leg pains, but the patient has to stop because the palpitations of our breathlessness. Then only it is considered an exercise for your heart. And so the main thing, the food intake, having a lesser fat or cholesterol item, especially the saturated fats, having more of polyunsaturated fatty acids like the fish or fish oils, and decreasing the carbohydrate and increasing the protein intake. So the focus has to be on diet, exercise, the diabetic or hypertension status of the patient, the other habits like the smoking or alcohol consumption, and the final thing, the lipid profile.
True. So, where do you see the role of omega-3 fatty acids? A lot of people, they start their supplements on their own fish oil capsules and stuff. Where do you see the role of those? Do you recommend, or you say there's no point?
So there are different components of the cholesterol. See, for LDL cholesterol or triglycerides, the problem is if the levels are high. So we have to reduce their intake. But for HDL cholesterol, the problem is if the levels are low. So to increase the intake, tablets can rarely increase their levels. So to increase the levels, we have to take adequate HDL containing things. That is the polyunsaturated fatty acids. And for non-vegetarians, definitely the first choice has to be the fish, preferably the salmon or tuna fish. For vegetarians, the best thing is to take the fish liver oil or cod liver oil capsules. But the problem is they will have a fishy smell. So most of the vegetarians, especially Brahmins, won't like to take even the capsules because of the fish smell. So for them, it's better they go for the flax seeds. So among the vegetarian food, flax seeds are the best things that can increase your HDL. So fish for non-vegetarians, the capsules, fish oil capsules for vegetarians who can take fish capsules. If for Brahmins or some strict vegetarians who can't tolerate fish smell or taste, they can go for flax seeds.
True. So I think we should follow that ourselves. So we'll just take one hypothetical case scenario as we are coming towards the end of the session. So let's talk about a 65-year man. He has diabetes of almost 12 to 15 years duration. The HbA1c is 8.2. The current treatment line is metformin and sulfonylurea. The ejection fraction is 30% with features of heart failure. The eGFR is about 40 and the albumin creatinine ratio is about 400. So we'll start with Dr. Sunita. So from the renal side, how would you change the prescription? As of now, the only drugs are metformin and sulfonylurea.
Okay, yeah. And 65-year-old male. And eGFR is like 40.
It's about 35, 40. Yeah. 40.
Yeah. 40. Anything between like 30 to 45, I would like to reduce the dose of metformin to half. If it is less than like 30, I'll like completely stop any sulfonylurea, and like he is like poor glycemic control. It is like 8.2. So from like CKD point of view, I'll directly, if EGFR is like 40, I'll have reduce the dose of metformin, and I'll introduce more renal safe drugs like DPP4 inhibitors, or another sulfonylureas like gliclazide or glipizide. And if patient is like not able to take those many medications, I'll directly go with insulin.
Right.
Because like SGLT2 inhibitors, they have like lot of things like renal protection, cardio protection, albuminuria reduction, everything is there, but the glycemic control is not like that good with these SGLT2 inhibitors.
Yeah, but they should still be there on board.
Yeah, it should be there. It should be there if the GFR is like more than 20. That will be there. There is no discussion about that. SGLT2 inhibitor will be there. Because of this glycemic control, I'll prefer these other drugs.
Yeah. So, Dr. Likita, from your side, let's say this patient cannot afford or does not want to take a GLP-1 RA, because I think that will be, of course, one of our first choices along with SGLT2. So, do you think the combination of an SGLT2 inhibitor with DPP4 inhibitor, are they good for such people? Because now, we'll have a long list of prescription drugs coming from nephrology and cardio also. So, where is the role of FDCs in such patients?
In patients with polypharmacy, especially elder patients who are having multiple consultations with an endocrinologist, nephrologist, and cardiologist, it's the fixed drug combinations are the best. Because I remember when I was studying, our nephrology departments, as soon as they're diagnosed with CKD, they have a list of 9 drugs. And adding something to the patient will be bringing boxes to us. Madam, I want to show you my medication. He'll be bringing a steel dabba with him. So even if we miss one drug also, I don't think that is good. So I generally go for fixed drug combinations, especially in elderly people with multiple comorbidities. So adding an SGLT2 receptor with a DPP4 inhibitor is very ideal. And for his creatinine, we have for his microalbuminuria, we have to go for high doses of ARBs, telmisartan. And if it's still not controlled on it, with SGLT2 and with telmisartan, it's not controlled, we have to add something. But if as his duration is also like 10 to 12 years, I still think, is there any role for sulfonylurea in this patient? Looking at a C-peptide might give certain insight into it, and we can either go for a low dose insulin or if needed, or continue sulfonylurea if his C-peptide is doing fairly well.
Yeah, true. So I think we've covered, maybe reducing the dose of SU or adjusting the SU, adding DPP4 if not GLP-1 RA, and SGLT2 inhibitors, and of course reducing the dose of metformin to 1 gram per day makes sense in such people. We've also discussed that SGLT2 inhibitors and RAS blockers must be on board, and possibly Finrenone also. So Dr. Sumant, the question for you is, at what point do you think you want to add antiplatelet drugs to these patients? Like, what are the indications for those? I still have patients of 15 years old saying, we take aspirin, we don't take statin. Why? Because somebody 15 years back told them that this is the drug that's going to save you. So what is the current plan?
No, for all the patients, we usually, if the patient has heart failure, especially with the ejection fraction 30%, unless proven otherwise, we have to start him an antiplatelet. Because unless usually he requires an angiogram to evaluate what is the cause of his LV dysfunction. So if the patient is having renal dysfunction with the raised creatinine values, we can do an angiogram. So for such patients, we have to presume that he is having an ischemic heart disease and keep him on at least a single antiplatelet plus statin. So one thing, we have to keep an antiplatelet and statin, and then for other components of heart failure, he has to receive an ACE inhibitor, ARNI, or ARBs, and also a beta blocker, a mineralocorticoid receptor antagonist, preferably Finrenone, and also an SGLT2 inhibitor. And depending on his symptom status, he has some fluid overload, whether pedal edema or bloating, abdomen, or orthopnea with bilateral crepes, we have to place him on diabetic as well.
True. So, would you like to add these 4 pillars together or one after the other, and how do you decide?
Usually, we add 4 pillars together, but at a lower dose. But
Yeah.
we won't start him on the optimum dosage, but we'll start at a lower doses. If there are no other contraindications, we will start all the 4, but at a lower dose. We gradually uptitrate because the most of the things, the ACE inhibitors are ARNI, and the beta blockers will be lowering his blood pressures. So the other drugs like SGLT2 inhibitors, antiplatelets will be starting directly the optimum dose of medications, and the RNA ACE inhibitors or beta blockers will be starting at a lower dose, gradually uptitrating the levels depending upon the blood pressures.
True. So very correct. I think we've kind of covered almost all aspects in a short period of time. A very interesting session. So just to conclude, I'll request one concluding remark from all of you. Dr. Sunita, any message for the audience?
Yeah, one thing is like regarding SGLT2 inhibitors, we have to start if we are starting the patient initial stages, we'll go with if EGFR is like more than 25, like 20 also, 20 to 30, we can start them. And if it is like decreasing in the due course because of the progression of the CKD also, we don't need to stop those SGLT2 inhibitors. We can continue till the patient goes on to RRT, like renal replacement therapy. That
I
is
think
from
that's
my side.
important. Yeah, that's a very, very important point, that even if the EGFR falls below 20, but the patient is hemodynamically stable, until and unless you've started renal replacement, please continue the SGLT2. The cardiorenal benefits continue even if you are not seeing any glucose lowering efficacy there.
Yeah,
Dr.
definitely.
Likita, any carry message from your side?
I think the glucose lowering effect is also very good, though not at very end stages of CKD. But I feel they were fairly good in all of the patients. Yeah. The glycosuric effect will very much act very much, I feel. If I want to add anything, it's like fixed dose combinations and regular exercise, and I always emphasize on fiber intake, which is very less in Indians, especially in South Indians. So fiber and protein intake, lifestyle.
I think that's universal across India, not just South India. We have commonalities across the country. Dr. Sumant, any carry home from your side?
The only thing is everyone should treat a cardiac disease or diabetes or CKD. So they have to be treated as a single entity, and one person having one thing. For example, a patient having heart failure should be screened for diabetes and renal dysfunction. And similarly, a patient having renal dysfunction should be screened for heart failure. Normally, the one thing that misses is all the patients with heart failure will be will do a serum creatinine and also check the glycemic status. All the patients with diabetes will do an ECG, echocardiogram, or creatinine. The only thing is all the patients with renal dysfunction may not be screened for LV dysfunction. That's the most common thing that is usually missed. So even in patients without symptoms, it's better to go for an echocardiogram at least a year.
Yeah, true. So I think the message is that we have to have integrated care, and we have to understand that we are not looking at just one aspect of the problem. We are looking at a bigger picture, and the sooner we start treating the bigger picture, the better the outcomes are. So with that, we started with a share, and I'll just conclude with another one today. चमने एक लाख में रंगे पू से बात बनती है, हम ही हम हैं तो क्या हम हैं, तुम ही तुम हो तो क्या तुम हो. So I think as specialists, we have to understand that dialogue and discussion among us actually makes us all wiser and richer, and it's actually befitting our patients. They get the best care they deserve. So thank you so much to all of you, Dr. Sunita, Dr. Likita, and Dr. Sumant. It was a pleasure to have you here, and thanks to all the audience for listening in.
Thank you so much.